Okay, ready to go. I'm very pleased to present Dr. Suzet McKinney, who I've known from afar for a long time, but I'm very excited to see your talk and exactly what you're up to during this COVID period, especially. Dr. McKinney serves as CEO Executive Director of the Illinois Medical District, where she oversees the implementation of the organization's strategic plan for economic development. Dr. McKinney is the former Deputy Commissioner at the Chicago Department of Public Health, where she oversaw the emergency preparedness efforts for the department, in addition to leading the department's Division of Women and Children's Health. Dr. McKinney holds her doctorate degree from UIC School of Public Health, woohoo, and she earned her master's degree from Benedictine University and her bachelor's from Brandeis. She has faculty appointments here in the School of Public Health and also at Harvard's T.H. Chan School of Public Health. And without further ado, I'm happy to present Dr. McKinney.
Thank you so much, and good evening, everyone. It is great to be here to speak with you this evening. So I do have a set of slides that I plan to present. I really wanted to talk about health security and a little bit about global disease as a threat, and then go into pandemics and try to hopefully help you understand why we are so concerned about pandemics and really sort of how pandemics behave and where they come from. And what I will do is, as I'm going through that, I guess I'd call it history lesson, I will weave in some of the stories and anecdotal accounts of what I've been doing for COVID-19. So hopefully that's okay. So just to get us started, you know, I would say that I am a public health emergency preparedness practitioner. I've worked in emergency preparedness and response for almost 20 years now. And so public health emergencies is what I know, and it is what I have done for a long time. I don't think a lot of people really think about sort of how we define public health emergencies and what some of their characteristics are. So I thought I would just level set us with information about that. So basically, we're talking about events whose scale, timing, or unpredictability threatens to overwhelm our routine capability for managing those types of emergencies, whether that is, you know, our resources are overwhelmed, our staffing is overwhelmed, or even the space that we have is overwhelmed. Typically, public health emergencies are very high in severity and cause increased injury, illness, and death. I think the point is that they just can't be managed with our normal day-to-day routine resources. So I also put this slide in just so that you would understand some of the capabilities that public health is traditionally concerned with and needs to have to respond to any type of emergency. So your emergency public information and warning, essentially how we communicate to the public, how we inform the public about what's going on, what we're doing about it, and what they should be doing to protect themselves. Distribution of medical countermeasures is another. So there's a lot of talk in the media right now about a COVID-19 vaccine. What I can tell you is that once a vaccine does become available, public health departments across the country will be looking to identify how they will deliver that vaccine to the public. So that's what's meant by distribution of medical countermeasures. And then a couple of others that I've indicated here on the slide. But if you'd like more information about the public health emergency preparedness capabilities, or perhaps the hospital preparedness capabilities, you can check the CDC's website as well as the website for the Assistant Secretary for Preparedness and Response for those capability documents, or simply just Google them. I should have put the links in, but I can send them. So some of the threats that we are most often concerned with are acts of terrorism, natural disasters, unintentional emergencies such as hazardous material spills. But obviously what is most concerning to all of us and what I plan to talk about this evening are pandemic influenza outbreaks, which is just one type of infectious disease outbreak that we are concerned about. So before I get into that, I thought I'd spend a little bit of time talking about health security. And that is because in 2009, the Obama administration issued a document called the National Healthcare Security Strategy of the United States. And in that document, it defined health security as a state in which the nation and its people are prepared for, protected from, and resilient in the face of health threats or incidents that have potentially negative health consequences. In 2019, the Trump administration actually updated the National Health Security Strategy. I've included the link here in case anyone is interested in reading the document in its entirety, or even if you're just interested in skimming through it. But essentially, the strategy focuses on 3 goals, and those goals really center around preparing the whole of government. So when we say the whole of government, we don't mean just public health or just homeland security, but all of government, all aspects of government, all levels of government, to essentially ensure that we all have the full spectrum of medical and public health capabilities to be able to support state, local, tribal, and territorial authorities in the event of an emergency. At the end of the day, what it boils down to is protecting our nation from the health effects of any of those emergencies that I just showed a couple of slides prior to this one. So when we think about global disease as a threat, the emergence of many diseases, many of which I've listed here on the slide, have caused infectious diseases to become recognized as one of the highest threats to our nation's security. So of course, back in the 1980s, we started with the HIV and AIDS epidemic. But what you see listed here are just a number of the threats that we continue to be concerned about. Maybe cholera, not so much anymore, but these others are still very relevant threats from a public health perspective. And, adding to the list, now we have COVID-19. So I think what is very interesting and was most striking to me is that in the 2009 version of the National Health Security Strategy, there was a quote in the document that indicated the threat of contagious diseases transcends political boundaries, and the ability to prevent, quickly detect, and contain those outbreaks with pandemic potential has never been more important. Again, that was in 2009. And then fast forward to 2019, and we see, 2020, and we see the emergence of COVID-19. One of the things that is very clear to us is that the global interconnectedness of our world, aided by international travel, really heightens the concern for not just pandemics, but other emerging or re-emerging infectious diseases. But again, I would just reiterate how significant it was, certainly to me, that in 2009, with the release of the National Health Security Strategy, we were made aware, if we didn't know already, of the critical importance of being able to prepare and protect our country against a contagious disease. So now I thought, just to talk a little bit about seasonal influenza viruses, because as we get into pandemics, what I hope is that you'll be able to see a little bit of the difference between the two. So I placed the definition of influenza here. I won't go over that. I think what's really important is to understand that flu strains are typically found in mammals. Birds and pigs, for the most part, are the most common hosts for what become human flu viruses. What we know is that seasonal flu really thrives in the winter. That's why we see it in the southern hemisphere first, and then we see it here. But essentially, seasonal influenza disappears in the summer. Actually, it doesn't disappear, it just moves to the next area of the planet that is experiencing winter months. Flu hosts usually develop an immunity to the virus after they have been exposed to it. What many people I found don't recognize is that seasonal flu vaccine is typically made up of the several strains that have preceded the current year. And so I believe I actually have that in one of the slides that's coming up. That's why we always talk so much and encourage members of the general public to get their flu shots every year. So with seasonal flu, what we also see is that there are certain members of our population that tend to be at higher risk. Obviously, the elderly, those that are over 65, children under the age of 2, and then anyone that might be chronically ill or immunocompromised. What happens is the flu virus is able to overcome seasonal influences and then mutate to change the immunity in its target population. So that is why the whatever the current flu vaccine is, that's typically why the vaccine contains strains several years prior. And once again, we always encourage folks to get a flu shot because we know that people who routinely get their flu shot will have a higher resistance to any emerging flu strains. Again, won't go over this slide, but this just lists some additional characteristics about seasonal influenza. What is very striking as well is routes of transmission for seasonal flu. Obviously, some of the more common are large droplets that are traveling through the air as a result of persons coughing or sneezing, particularly without covering those coughs and sneezes, or coming into contact with the saliva of an infected person. And then a more rare route of transmission would be airborne, but over a long distance. I think what's also striking about seasonal flu and what many people don't realize is that seasonal flu actually causes about 36,000 deaths per year. But typically we see the vast majority of those deaths in those that are over the age of 65. When we talk about pandemics, and I think especially in the very beginning of COVID-19, there was a close attention was being paid to the number of deaths, but then there were also people who were saying, this is nothing, seasonal flu kills more people every year. And while seasonal flu does kill a number of people every year, I think what we've seen with COVID-19 obviously has far surpassed what we see with seasonal flu. And here it is, this is how we spread flu. And in many cases, some other diseases as well. So again, it's a cough or a sneeze that is not covered. And so public health messages during a typical flu season always indicate the need to cover coughs and sneezes. But in the case of COVID-19, we are saying the same, but those messages are now coupled with other messages such as wear a mask or some other facial covering. But despite this, so many people are still opposed to this form of protection. And I'm sure all of you have seen probably countless stories in the media, if not the mainstream media, certainly on social media, about people being shamed or ridiculed or criticized for not wearing a mask or some other form of facial covering. So what I hope is that the messages are beginning to permeate, but I do believe that we still have a number of people in our society who are just opposed to this level of protection. So in terms of pandemic influenza, moving beyond seasonal influenza, what we're talking about now is a brand new strain of influenza, or a novel strain, if you will, one that we've never seen before, and as a result, no one will have immunity to the new strain. What we also see with pandemics is that there's typically a higher disease attack rate, but also higher death rates than normal or seasonal flu, which again is what we are seeing with COVID-19. So some of the past influenza pandemics, and I'll get to this first one in a later slide as well. The 2009-2010 swine flu or H1N1 was actually a pandemic. It did not reach the magnitude of what we are currently seeing with COVID-19, but if you compare the characteristics of H1N1 against the WHO pandemic risk scale, you can see that it was a pandemic. And I do have that coming up in just a couple of slides. But also 1968 and 69, we saw the Hong Kong flu, we saw the Asian flu in 57 and 58, but by far the worst case scenario that we've seen with any pandemic was the Spanish flu in 1918 and 1919. Uh-oh, let me just go back. So this is a photo that depicts a surge hospital in 1918. Interestingly enough, if you look at the photo very closely, what you see are cots or beds just lying down this facility, and this facility was being used essentially as an overflow or surge facility because hospitals at the time were overwhelmed. I did include the link here for the Business Insider, which is where I found a couple of photos. But if you go to this link, you will see many more photos from the 1918 pandemic and somewhat of a narrative description as to what's depicted in the photo. So it will give you an idea of how the United States dealt with this worst case scenario pandemic back in the early 1900s. Interestingly enough, present day COVID-19, we aren't calling them surge hospitals, but we are calling them alternate care facilities. And this is actually one of the activities that I have been working on for COVID-19. I've been serving as the operations lead for the state of Illinois for their COVID-19 alternate care facilities. So many of you may have heard about or read about the McCormick Place. McCormick Place was one of 5 alternate care facilities that the state of Illinois identified to serve as overflow facilities in case our hospitals and our healthcare system across the state became overwhelmed with COVID-19 patients. What you see on the slide here constitutes the definition of an alternate care facility by the U.S. Department of Health and Human Services. So just wanted to make that clarification. But in addition to McCormick Place, there were 4 other hospitals that had been closed. And we brought in a team from the U.S. Army Corps of Engineers, as well as a number of construction and engineering teams to essentially perform improvements on these hospital facilities such that we could get them back up to the level where they could accept patients and actually provide clinical care. So one of the lessons that we've learned so far in this journey is that as a convention center, obviously as well constructed as we were able to do it, McCormick Place was not the optimal location to be caring for patients, especially patients who were non-ambulatory and needed assistance just moving around, trying to get to the shower or to the bathroom facilities. And so we demobilized McCormick Place fairly quickly. And then we decided to focus all of our efforts on one of the other alternate care facilities that we were placing within a prior hospital. And so what we've been doing for the last several months is bring in a clinical team and all of the wraparound services that are required in order for a hospital or clinical setting to be able to care for patients. And I mentioned a vaccine earlier. Here's another photo from the Business Insider that shows a mass vaccination facility in 1918. So I show these photos and I talk about 1918 pretty much in depth because as a public health practitioner, it is troubling to me and it is baffling to me how here we are in the year 2020, over 100 years after the 1918 pandemic, and we are still using the exact same mitigation measures that we used back then. So for me, when I look back over these photos, when I read historical accounts of what happened in 1918, it eerily resembles some of the very same things that we are experiencing now in 2020. Again, I've listed some of our prior influenza pandemics here, and for this slide, also indicated what the mortality rates were from those pandemics. So if you look at 1968, 69 with the Hong Kong flu, that, I guess we really wouldn't consider that horribly serious because the mortality numbers are very similar to what we see on an annual basis with seasonal flu. About double that with the Asian flu, but again, you look at 1918 and you see a mortality of over 20 million people worldwide. So, we all hope that COVID-19 doesn't get there, but I think we're about halfway there at this point. So to talk a little bit about just the behavior of pandemics, what we know is pandemics typically tend to spread around the globe in waves. So what you see in this graph is from 1918, and you can see the 3 waves in which the Spanish flu circled the globe over a period of about 6 to 9 months. So you can see the first wave was in late June and July, and then cases and deaths sort of hit a very low level, low plateau. But then you get to the fall, and the second wave comes back around and peaks much higher than the first wave. And then you move into the next year, 1919, and then you see in the spring of that year a reemergence of a third wave of that situation. One of the other things is in the 1918 pandemic, we saw a very high death rate among young adults. So remember I said in the beginning, seasonal influenza, for the most part, heavily impacts older adults. But in 1918, we saw 25 to 34-year-olds being more heavily impacted than the older generation. And so that's what you're seeing in this graph here, just a depiction of the multiple age groups and the peak of where the majority of those deaths were in terms of age group. And this is just another illustration of the same. So you see again, in September, October, and November, the highest rates of death were among those in their 20s and their 30s. When you look at those over 65, the death rates were fairly low. So here what you see are just some additional effects of pandemics, particularly the extreme disruption to societal functioning, also significant impacts on the economy, reduced travel and tourism, and most significantly, I would say, no assistance from other areas, no ability to obtain assistance from other states or other areas of the country because everyone is impacted. So once again, this is exactly what we are seeing with COVID. So now I thought I would just sort of take you through a couple of pandemics or a couple of infectious disease outbreaks, I should say, that we've experienced over the last few years and show you how we tend to make a determination as to whether or not those diseases reach their pandemic potential. So H5N1 originally began to emerge or circulate in 2003 in Asia. It was highly pathogenic and originated in birds. The virus changed quickly and changed often, and there was extreme concern that H5N1 would not just jump from birds or chickens to humans, but then that it would reach the point where it could be transmitted, sustained transmission among humans. So here's the question. What's the pandemic, or what was the pandemic potential for H5N1? Was it an actual pandemic? Well, I think what we saw is that while it did create a number of cases and about 50% of deaths, so very high fatality. We only saw human cases come about as a result of the very close exposure to birds. It never reached the point where there was sustained human-to-human transmission. What's interesting with H5N1 was that Tamiflu and Relenza antivirals were viable treatment options, supportive treatment, but viable nonetheless. In comparison with SARS, you can see the figures here on the slide. But when we look at whether or not a new strain of flu is actually a pandemic, we really look at it from three different requirements. Is it a novel strain? Does it cause significant disease in humans? And can it maintain consistent human-to-human transmission? So in the case of H5N1, it was not a pandemic because it did not meet all three of those requirements. It only met two. But then, and here is the WHO pandemic risk scale. So you can see that H5N1 achieved a score of 3 on the WHO pandemic risk scale because, again, it had little to no sustained human-to-human transmission. Now, if we move forward to 2009 and the H1N1 swine flu, we saw that H1N1 increased rapidly and spread across the U.S. to all 50 states. Unlike H5N1, which started in Asia, H1N1 started in Mexico. But it did spread across the globe very quickly. What we saw was that this strain was also capable of causing severe disease and death. And then when we put H1N1 to the test with these three requirements, we see that it met all three requirements. So H1N1 was a pandemic virus. However, it did not reach the level of severity that we thought it would reach. Nowhere near the severity of 1918, really not that close to what we see in seasonal influenza. But again, because it met all three requirements for what constitutes a pandemic virus, we did classify H1N1 as a pandemic. The slide or the picture that you see in this slide, and I also included the link for it, really just shows how widespread H1N1 was across the United States. This was for the week that ended October 24th of 2009, so literally just 11 years ago. And this was right about the time, this is actually on CDC's website, the last reporting of cases of H1N1. So once again, when we put H1N1 on the WHO pandemic risk scale, you see that score of 6 at the bottom with efficient and sustained human-to-human transmission. So, what's the point? I think the point that I wanted to make here is that pandemics are not new. I do include a link here for a graphic that shows the history of pandemics from the Antonine Plague all the way up to current day with COVID-19. I think from a preparedness practitioner's perspective, preparedness for pandemics is key. We need to be working to develop new strategies, new tools. We need to be working to obtain and stockpile sufficient supplies and resources so that we don't see some of the same challenges that we saw in the early days of COVID-19 with extreme shortages in personal protective equipment for first-line healthcare workers and ventilators and other types of protections and resources for patients who are suffering from COVID-19. So this is the photo here, or the graphic, I would say. You cannot see it very well on the slide. And again, that's why I provided the link. It's very interesting. And let me just go back one slide. The link that you see here to the Visual Capitalist website will take you to a large version of this graphic. But if you go to the graphic and take a look, it shows detailed information about pandemics from the Antonine plague, which I believe was 165 I guess it's AD, all the way through to COVID-19. But it also includes a lot of data and information about mortality rates and other things. So if you are interested in this type of thing, it's a very compelling graphic and gives a great historical perspective. I think, once again, it drives home the point that pandemics are not new. And so I have encountered many people that ask me, why weren't we better prepared for COVID? And I think that there are a number of reasons. I think from a public health preparedness perspective, the federal government, Congress, appropriated $1 billion in 2001 to improve and shore up the public health infrastructure in the United States for the specific purpose of having the ability to protect our country from, in the early days, it was bioterrorism threats. But from 2001 up to current day, we've had a number of additional threats emerge that funding is now supposed to be utilized to help us prepare for those threats. And it's all the threats that I talked about in the very beginning this evening. I think the challenge is that traditionally with public health threats, we are not necessarily seeing buildings blowing up. We're not seeing people, succumb to disease in the middle of the street. And so when government officials are looking for places to cut funding because budgets are tight, what we've seen over the last almost 20 years is that oftentimes this funding is the first to be hit. And so, as I mentioned, it was a $1 billion appropriation in 2001 after the 9/11 attacks and the anthrax attacks in October of 2001. But this funding to public health has been cut every single year since. We saw a slight increase in the funding allocation in 2006 and 2007, but that was the time when we became incredibly concerned about the spread of H5N1 or the avian influenza in Southeast Asia. So I think that's one of the reasons why we weren't better prepared for COVID-19. I think another reason is competing priorities. Natural disasters, hurricanes, flooding, tornadoes, unintentional emergencies, things that we see every day. Train derailments of train cars that were carrying hazardous materials. Overturned semi-tractor trailers on the highways that are carrying hazardous materials. And so I think over time, there was one point where we were heavily focused on pandemic preparedness, and then with all of these other threats that have emerged or come to the forefront, pandemic preparedness just became a competing priority. Another reason I would say is complacency. We had H1N1 in 2009, and it didn't rise to the level that we thought it would, so we got a little comfortable. And then I think finally, ignoring the signs, ignoring the warnings, ignoring the advice. And I make it a point to stay away from any particular political side. What I do instead is I advise people to read the information that's available and become informed citizens and educate yourselves. And I think that, there was a lot of information coming out of China and other places with regards to COVID-19 that should have alerted us that we were going to see something here in the US. And so with that, this is really my last content slide. There's been a lot of talk in the media about the group within the National Security Council that had done so much work under the Obama administration preparing us for pandemics. There's been a lot of talk or debate, I should say, as to whether or not the current administration paid attention to those warnings. There's also been more talk about how the current administration disbanded that group within the National Security Council. So I just decided to do a little digging, and take my own advice and become an informed citizen. And lo and behold, I found the documents. And so I decided to share those with all of you. Do with them what you like. But what you see here, the very first one is the White House Pandemic Playbook that was developed by that group within the National Security Council. The second is a briefing that the outgoing administration provided to the incoming administration. And then just a few articles from Politico and another source that just sort of discuss what they believe transpired in the transition period between these two administrations. So with that, I think I will stop and we can perhaps get to some questions.
That's great. Thank you very much. Megan is going to ask the questions that people put in the box as well as her own questions. So I think there's one so far.
Okay.
Dr. McKinney, yeah, we'll give some people time to kind of type questions they have, or, if people in the class are also welcome to raise their hand and ask a question as well. First question would be in regards to the 1918 pandemic. Why do you think people in their 20s and 30s were most affected in the 1918 pandemic?
I think that's a great question. We don't have any, sort of sound evidence that tells us why people in their 20s and 30s were more heavily impacted. I would venture to believe it probably has something to do with the fact that people in their 20s and 30s are the ones that are out and about most often, moving around, interacting with people in public, as opposed to, our older populations. While they can very well move around and interact with others, it's not in the same manner that folks in their 20s and 30s are doing, going to work, going to social gatherings, and just being out in public, large venues, whether those are sporting events or movie theaters or music concerts and things like that. So those are some of the reasons that I believe people in their 20s and 30s were more heavily impacted in 1918. If you look at some of the things that we've seen with COVID-19, at one point we were seeing a surge in cases among young people, again, because they were congregating in bars or having quote unquote COVID party. And so I think it's just a factor of the sociability, if that's even a word, of our younger generation.
Thank you. The next question is, are you concerned about an explosion in the fall cases similar to the flu? We seem to be trending in that direction anecdotally. I know quite a few friends who never stopped hurting, but was outside, so it was okay. But now with everyone being forced indoors, this is confusing. So I guess the question is, I think, are we going to see just another huge spike in cases?
I am concerned about seeing another spike in cases. I mean, we can see now that cases are beginning to surge, and quite frankly, I think that's a factor of, people are experiencing what's being called COVID fatigue. Everyone's tired of self-quarantining. Everyone's tired of wearing masks. Everyone is tired of limiting their movement. And so people are beginning to relax and go back to some of their normal patterns of behavior. And I think that is contributing to the surge in cases that we are seeing, certainly in states like Illinois and places like Chicago, because we had gotten our case incidents under control so very well. And now it seems as though as standards, or I'm sorry, not standards, but as restrictions are being lifted more and more, and people are going out more and more and congregating, we're just seeing the cases shoot up. If you look at some other states where they didn't implement restrictions as strictly as we did here in Chicago and the state of Illinois, many of those states, particularly in the South, never really sort of came down in their incidence. So I'm very concerned about it. I'm very concerned about the possibility of us having to go back to some of those more restrictive measures. And then the other thing that I'm concerned about is, for students, college students who have been able to go back to their campuses and maybe doing very well on those campuses, those students are coming home next month for Thanksgiving. And I'm concerned that, we're going to see situations where some students decide, okay, I've been here, I followed all the rules, let's do a bit of partying before time to go home, and then they will come home carrying COVID. So lots of concerns there for me.
Thanks, Dr. McKinney. Yeah, I have my question related to that. If you can hear me okay. Yeah, and kind of regarding that complacency, it seems to be kind of a common theme, whether it's currently, we have the COVID fatigue that you mentioned, or complacency after a pandemic, with kind of the decreasing government funding. Do you have any suggestions or thoughts on how to fight this kind of complacency?
I think it's difficult. I was actually speaking with someone today, and we talked quite extensively about how here in America, we have become accustomed to a certain way of living. We have become accustomed to certain rights. And so many of us don't feel as though, we have to follow some of these safety precautions. And that within itself is a form of complacency. I see it quite often just in everyday matters. Think about the last time you watched the news and you saw a story about a robbery, in any given neighborhood. And they interview a resident of the neighborhood, and what does the person say? Well, that kind of thing just doesn't happen here. Well, yes, that kind of thing does happen here. None of us are immune to these situations, whether it's a robbery in your neighborhood or, increasing cases of an infectious disease outbreak. And I think that just that mindset is a form of complacency. I think there is a heavy burden on government, particularly governmental public health, to continue to put those messages out there. But I think for those of us who study public health, who work in public health, there's also a bit of a burden on us to educate our friends and our family members around what we should be doing and the types of precautionary measures we should be taking. So those are just some of the practices that I try to employ personally to educate those around me, those that are in my personal circle, because we can't depend on government to do it all. We can't depend on the media to do it all. So for those of us who are more informed and really understand, I think there is a burden on us to spread those same messages.
Thank you. That does sound like an action I think we all can take. The next question is, since the 1918 pandemic came right after World War I, where tons of people were coming back from the war front and the trenches, do you think the very high death toll then is more attributed to the deadliness of the disease or the wide distribution worldwide?
I would say both. Obviously, the widespread distribution was certainly a factor, but if you look at those death rates and also you look at some of the conditions I think that the disease not only spread very rapidly, but just it had a very high mortality rate, infectivity rate, and mortality rate. And I also think that they just weren't able to apply some of the mitigation measures in a manner that enabled them to minimize disease spread and death from the disease. Again, I think I said this early on, I am very troubled by the fact that the very same mitigation measures that were used in 1918 are the ones that we're using now in 2020. And we are seeing some of the exact same effects. So again, I think it was both.
Got it. Thank you. Just curious, in the US for the 1918 pandemic, were masks recommended?
Yes. And I would encourage you to take a look at that Business Insider link that I included, because you will see police officers, law enforcement officials wearing masks. You'll see members of the public wearing masks. You'll see a lot of the same things that we're seeing currently.
Gotcha. Next question is, while waiting for the second wave, what lessons can we learn from Asia?
I think one of the lessons that has been so striking to me, the United States and South Korea reported their first cases of COVID-19 on the exact same day. The spread of the disease and the height of the disease in South Korea didn't last very long, certainly in comparison to the United States. At the end of it, South Korea saw about 8,000 cases total, and I want to say somewhere between 700 and 800 deaths. And so here in the US, where are we? We're over 8 million cases at this point, and several 100,000 deaths. And what I've seen and what I've learned is how South Korea and government officials in South Korea, and even the public in South Korea, really put the health and safety of their residents ahead of people's perceptions or perceived rights, if you will. So what did they do? They implemented widespread testing pretty much immediately. They implemented all the same safety precautions: wash your hands, wear a mask, social distance, pretty much immediately. But the other thing that they did, testing. They implemented widespread testing immediately. The other thing that they did in South Korea was implemented a contact tracing program very, very quickly. And with their contact tracing program, they utilized technology to track phone data and credit card data. And so the anecdote that I always use is, if your COVID test, if say you went to the grocery store and you used your credit card to pay for your groceries, and then a day or two after you get the results of your COVID test and it's positive, because you use your credit card in that grocery store, they are able to track that and make a notification to the grocery store that someone who was COVID positive has shopped in their store on this day at this time. So what that did was it enabled the public health system there and even businesses to have their employees tested, to notify others who had been in the store at the same time so that those people could get tested. And what that comprehensive contact tracing enabled them to do was to identify cases very quickly and get people the treatment that needed it. I don't think that form of contact tracing would work here in the United States, but I think it's primarily because we would perceive, cell phone and credit card data tracking as an infringement on our human rights. But for me, the lesson there is that, with something like a widespread pandemic, sometimes we have to do things, and perhaps should do things that are a little bit uncomfortable, that we may not do on a normal day-to-day basis, but we can see the extreme differences in the COVID-19 outcomes in South Korea versus the United States.
Thank you. I had not heard about the credit card and the cell phone data use for tracking.
Yeah, it's pretty amazing what technology can do if we would utilize it in that manner.
Yeah. Next question is, the current overflow facilities fill up, will we go back in Chicago or in Illinois, will we go back to McCormick Place, the McCormick Place overflow model?
I hope not. I can tell you that, so with the current facility where we focused all of our energies, we have a capacity for just under 500 patients at that facility. Honestly, in the discussions that I've been involved in with some of our healthcare system partners, I think that our healthcare system has learned a lot from how they managed the first wave or first surge in cases of COVID. I think things would be done a lot differently. If we get to a situation where we have to go back to McCormick Place, we are in big trouble. At this point, I don't see that happening. I don't see us going back to McCormick Place as an overflow model. I think hospitals will be much more savvy in how they manage COVID patients. I pray to the heavens that our long-term care community has learned quite a bit and is more savvy in terms of how they will handle cases. But I say all that to say, I think we are in a pretty good spot with the overflow capacity that we have currently. And we are in regular communications with the healthcare system in terms of what they're seeing. And we are monitoring bed availability, particularly bed availability in ICU departments across the state, as well as critical care beds across the state. So I feel as though we are pretty well equipped to be able to see when and where we might be getting into trouble and can adjust.
Got it. Thank you. That does make me wonder. I have an echo. So if a state like Illinois, say we are, we have good precautions and our positivity rates are generally low, do we kind of have a chance of staying that way if all the states around us start getting out of control?
Mm-hmm. Yeah, I agree. I mean, we've been communicating very closely with folks in Wisconsin, particularly Milwaukee, because Milwaukee is having a very difficult time right now. The alternate care facility that we have here in Chicago, we have gotten it to a state that it's ready to accept patients, but we aren't at a point where patients need to be treated there. Milwaukee accepted the very first patient in their alternate care facility yesterday. So for us, that speaks volumes. I am concerned still for Illinois because, again, when you think about people who just have COVID fatigue and, don't want to go back indoors, want to be out socializing, going to restaurants, going to bars, it's so very easy to cross over into Illinois from Wisconsin. So I think here in Illinois, we just have to be hyper vigilant. But that's also why I am concerned that we might see some of those restrictions that we saw early on being re-implemented. In fact, I believe I saw a report this morning that 3 or 4 counties here in Illinois have gone back to the phase 2 restrictions. When you look at Indiana, Indiana's having a bit of a difficult time as well. So again, all the more reason for us to remain hypervigilant here in Illinois, but we are certainly at risk of seeing even more cases because of, what our neighbors are seeing.
Got it. Thank you. Next question is about UIC. UIC has controlled the number of COVID cases on campus, which is great. Many other universities are still struggling with getting things under control. What would you recommend that these universities do? I think there should be a space for staff at universities to exchange ideas on how to keep everyone safe.
Mm-hmm. So I think that universities need to understand that, implementing one measure is not good enough. Measures have to be targeted and they have to be layered. And what I mean by that is if you are going to conduct testing on campus, great, conduct testing. But you can't conduct testing and not require people on campus to wear masks and to socially distance. From what I've seen, the colleges and universities that have done very well controlling COVID on their campuses are the ones that require mask wearing, require social distancing, re-emphasize messages around good hand hygiene, but also are doing testing, some targeted testing, some random testing, as well as limiting visitors to campus and limiting travel. I actually have a college-age daughter, and her school required everyone to do a 14-day self-quarantine prior to returning to campus. They sent test kits home for everyone to be tested, but as soon as they were on campus, it was the masks wearing, the hand hygiene, the social distancing. They've now implemented surveillance testing, and they've also maintained a large number of isolation beds so that anyone who is tested positive can be isolated from the general population. Where they have seen some cases, it's been in students who are commuter students. And so I think, again, we just have to have these targeted and layered strategies. And, I think that there does need to be space for faculty and staff to collaborate and develop new strategies, perhaps even non-traditional strategies that can help control spread on campus. I think, finally, the last thing I'll say about that is where we have seen campuses that just have no control are campuses that are in states where they haven't implemented some of the more restrictive precautionary measures.
Yeah, I'm just curious, do you know of any maybe websites or anything off the top of your head where universities can collaborate on these measures?
I don't. From what I've seen, every university that I've seen has developed their own plan, some in collaboration with their local or state public health departments and some not. But I don't know of any sort of cross-university collaborative spaces.
Okay. Next question is, do you think we'll potentially see less cases of flu this winter because more people are wearing masks and social distancing than in past seasons?
I think that's quite possible, but I also think, we've been looking at the Southern Hemisphere and how they've been faring with seasonal flu, and it really hasn't been that bad. They aren't experiencing any extreme levels of cases of seasonal influenza. It could be because people are social distancing and wearing masks. It could also be because people are a little bit more aware and are getting their flu shots. We just don't know for sure yet. So what we're doing here is encouraging people to remain vigilant with those measures, but also encouraging people to get their flu shots.
Next question. How successful do you think the mayor's travel ban is? At this point, it covers 30 states and Puerto Rico, which seems unsustainable, and it has no enforcement mechanisms.
You know, I would agree with that. It is very difficult to enforce, essentially impossible to enforce, and I believe that it is premised on the assumption that people will be honest about where they are traveling from. I honestly feel as though the travel ban is probably instituted as a deterrent, you know, in the hopes that people just won't travel. But because there aren't any obvious enforcement mechanisms, I think there's no way to capture people who are coming from any of the states that are on the list. And there's certainly no way to track them once they arrive. So if you look at it from that perspective, it's probably not highly effective or highly successful.
It does make me wonder with tracking, do you know if there's any way to track to see if the ban has been a deterrent, maybe to change others' minds?
Yeah, not that I'm aware of. I honestly think that our local officials have just been working so diligently to control things here and try to provide care for, you know, more of our vulnerable populations. I don't think there is the time or the money to implement any sort of tracking mechanisms. You know, you're talking technology, very expensive technology, and a way to make, you know, various aspects of technology interoperable in a way that they, you know, pieces of technology can communicate with one another in order to track someone. And I don't think we have the resources to do that.
Thank you. So it looks like we've gotten through all the questions in the chat so far. I do have a few more that I can ask, or Linda, do you want us to keep going with questions?
If you have more questions and Dr. McKinney is willing to stay on a little bit longer, that'd be great.
Sure.
Yep, I can stay on a few more minutes.
Did anyone else have a question?
Yes.
Yeah, sorry, go ahead.
Oh, sorry. Hi. Hi. So my name is Ariel. So I have a question about I guess the mayor during the pandemic, she noticed that like Black people and Hispanics were like having the higher number of COVID cases, and she tried to like, I guess, put in like measures that would help those populations like not get COVID as much, but I feel like I don't know, like I feel like she didn't do it properly. Like I noticed that when I'm Black, so I'll go down the street and there would be like people that like cover their faces when they'll see you walk by, and I'm like, well, I don't have COVID, so I feel like she's been helping, like I guess it's a stigma that Black and Hispanic people are not like taking precaution. So what would you recommend that the mayor do to properly like enforce I guess strategies to help populations of people who are getting COVID-19 more than others?
Well, I don't think it's so much a stigma with Black and Latino communities. It's very well documented and very well evidenced that certain communities here in Chicago, particularly Black and Hispanic communities, experience healthcare disparities at much greater rates than their non-minority counterparts. So I think that's the first thing. I think the mayor's efforts were, for those particular communities, were not so much enforcement. What I've seen and what I've had some involvement in is her efforts were really to try and infuse resources into those communities so that they could minimize some of the disparity in cases and disparity in resource availability for those communities. I think from an enforcement perspective, there's really no way to forcibly enforce large groups of people social distancing, wearing masks. So what she has had to do is really just try and appeal to the public to follow the safety precautions. While our public health department here in the city, as well as the state and other counties that surround the city, public health commissioners, public health administrators have the authority to enforce quarantine and isolation, but you can't do that on entire population. And so in this situation, the only option available, whether it was to the mayor or to the governor or to mayors of other suburban cities and towns, is to really try and appeal to the public to follow those safety measures. I think that I think she's doing all that she can do, but COVID is not the only thing that we're dealing with. We're dealing with extreme rates of disparity in those very same communities of chronic health conditions. We're dealing with racial unrest. We're dealing with challenges with our police department, and so many other things, So I think I would just say I don't envy her.
Thank you.
That's definitely a good question and something to consider then after the pandemic too.
Agreed.
I kind of wondered, is there anything you would recommend for another population that I think is being affected are those that are essential workers. And well, I guess in a hospital you kind of have, I would think, more PPE. Is there anything more that maybe the government or I guess regulations can do for those essential workers in supermarkets and people just interacting with the public, with a lot of the public day to day?
In terms of providing them with more PPE?
I guess more PPE, or I'm not sure if there's anything additional aside from social distancing and PPE that can be done to help that population.
Yeah, I think the challenge with essential workers, particularly those working in, grocery stores and other retail outlets, but even, transportation workers and other public safety workers, I think the challenge there, or the biggest issue, is that they work in jobs where they are unable to work from home, like so many of us. And so as a result, they are out in the workplace. They're out in public, traveling back and forth from home to the workplace. And so there is, a greater risk of exposure. If you think about a bus driver or other type of transportation worker, they have to travel from home to work. And then, in the case of a bus driver, they're driving a bus for, 7, 8, 9 hours a day. How many people are getting on and off of that bus? And so their risk level is heightened because of the number of people that they're coming into contact with, as opposed to someone who works in another industry where they can remain at home and do their work from their computer on Zoom calls all day, like many of us do, and we just aren't coming into contact with as many people. I think this is why in every retail outlet that you go into now, and even on buses and trains and other public venues, you are seeing the essential worker not only wearing a mask, you're also seeing them wear gloves, and you're seeing them being shielded by a piece of plexiglass. I've even seen the case with bus drivers where, it's like an entire, almost like little plexiglass cocoon that they're sitting in. So I think that's the biggest challenge with our essential workers, just that they have a greater risk of exposure because of all the people that they're coming into contact with every day.
Yeah, I think things have gotten a lot better since the very beginning.
Yeah.
We do have another question in the chat. In terms of IMD, does one facility have greater capacity to handle COVID patients than others? Are there contingency plans for transfers and et cetera?
I wouldn't say that one facility has a greater capacity to handle COVID patients. I wonder if the person who's asking the question is referring to the fact that one of our hospitals in the IMD, Rush University Medical Center, sort of has this special designation. When the new hospital tower there was built, it was designated as the bioterrorism hospital for the state of Illinois. But essentially, it's just because they built into the facility increased capacity to convert their emergency department and several of their rooms to negative pressure rooms. They have the ability to expand their surge capacity by utilizing, additional space and plugs and things of that sort in their lobbies to provide patient care. Across the 4 hospitals in the medical district, that represents over 2,000 beds, actually over 2,200 beds, but one of the hospitals is a veterans hospital. And so it primarily treats veterans. But one of the things that myself and my team did very early on in COVID was convened not just the 4 hospitals in the medical district, but there's a 5th hospital just about a mile away, Mount Sinai Hospital. And we coordinated those hospitals in conversations around surge capacity and resources such as PPE and ventilators, because again, I'm a preparedness professional. So my thought process was, if these 5 hospitals can work together to share resources, then that helps them sustain themselves for just a little bit longer without needing immediate assistance from city or state officials. And so, again, I wouldn't say that one hospital has greater capacity. What we do have is a mechanism for coordinating among not just the 4, but 5, so that we can kind of balance that capacity across those 5 institutions.
Thank you. My last question is on human-to-human transmission. I remember that from one of your earlier slides. I was wondering what is required for sustained human-to-human transmission. Is it just a lot of time, or is it more dependent on the characteristic of a virus or pathogen?
That's exactly what it is. It's more dependent on the characteristic of the virus. As I said, many of these viruses mutate rapidly. And in some forms, they just don't have the ability for sustained human-to-human transmission. But they can mutate to a form where they can then have sustained human-to-human transmission. If you think back to what we saw with avian influenza, again, that was primarily a disease among birds. But what we learned is that where we did see a jump in the disease from a bird to a human, the vast majority of the time, it was because you had households where, chickens, birds are commodities, and it was an economic thing, basically, where people were fearful of their chickens being stolen, and so the chickens lived in the house with the humans. And so that was really the cause of the bird to human transmission. But when the bird was removed from the scenario, the virus just didn't have the ability to sustain transmission from human to human. So very much a characteristic of the disease.
Thank you for explaining that a little further. I don't have too many more questions left on my end. Is there any more questions from the class? If anyone wanted to raise their hand. Dr. Force, do you have any more questions?
No more questions. I think we have to let Dr. McKinney go. So I want to thank you very much for a super interesting talk. I'm going to look up those references that you put on your slides because this enhances my understanding.
Sure.
Much more than I thought it would, to be honest. So thank you so much for a great lecture and great to see you in action, and have a great evening.
Thank you. Thank you so much. It was great to be here. I really enjoyed talking with all of you. So enjoy the rest of your evening.
Thank you.
Thank you.